delegates who have been with us through Medanta Echo and Cardiology for the last 10 years. With the good wishes of Dr. Parashar and Dr. Roxy Senior, we start off the 10th series of the Best of Cardiology series that we started when we moved to Medanta. And this is a virtual session, as you know. Hopefully by next year, by middle of this, by later this year, maybe things will improve. So all of us are passing through a difficult phase. We all know that it's really bad. But the very fact that we are all here shows our deep interest in science and to at least take things forward in the right direction. So I'm privileged today, truly, to have Dr. Parashar, Dr. Roxy Senior, a good friend of mine, and of course, somebody without whom I can't exist, Dr. Manish Bansal, my colleague of the last 15 years or so. I'll just say, so before I start, let me just introduce Dr. Parashar, who's an icon in the field of echocardiography. And he's an icon not only in India, but he's an icon all over the world in the field of echocardiography. And I remember going to his lab at the R&R, the Army Hospital, where he was a colonel, a very distinguished person, and tried to look at M-mode echocardiography when I joined as a senior resident at the All India Institute of Medical Sciences, at the time when there was only one All India Institute of Medical Sciences. After that, Dr. Parashar had a checkered career. Coming out of the army, he was one of the few people who was both president of the Cardiological Society of India, which is prestigious in itself, and also the president of the Indian Academy of Echocardiography. And under his guidance and under his constant striving for perfection, we also came out with a textbook of echocardiography. And I must say, the Indian Journal of the Indian Academy of Echocardiography has taken shape. He himself has made personal contributions, and it is widely said in India that, you know, if you have an echo conference and if you don't have Dr. Parashar, then it is incomplete. So as I promised to him that, look, if I start giving your CV and Dr. Roxy Senior series, then it will be very nice. We'll go up to dinner time. But before that, we need to have a lot of science. So Dr. Parashar, I hand you over the mic just to say that the theme today in the Best of Cardiology series 10 and the virtual meeting 8 on 24th of April is putting latest science in clinical context. And we have seen that in the pandemic, that how science came in the setting of the clinical scenario. So Dr. Parashar, over to you, putting latest science in clinical context. Over to you, Dr. Parashar.
So, as you said, putting the latest in the science also, I think today we have Professor Roxy Senior. Like me, but when any conference in India is incomplete without his presence also, and his biodata, I think, has already been focused, or he'll show it somewhere else. Yeah.
Yes,
if you see, again, as Dr. Kastiwal said, that if you start reading all his biodata, but yes, he is one of the greatest persons who has developed a contrast echocardiography in the world. He has done a lot of work on aortic stenosis. He's on an editorial board of JSCC Imaging, which is a very, very prestigious sort of a journal, published a large amount of papers also, and he's a professor of clinical cardiology also. As I gathered today, that possibly the talk of his is related to aortic stenosis. And aortic stenosis, as you know, as the theme says, that there has been a lot of advances in the field of aortic stenosis. And as you know, that because of the increased life expectancy of our individuals and the stress to which the aortic valve is subjected, hemodynamic stress, I think its incidence is going on increasing as the age advances. Though there may be various, everybody has given different figures, but I think somewhere near the age of 70 to 80, almost about 5 to 8% have got a moderate aortic stenosis. One of the key factors in aortic stenosis is to get a precise severity, and the precise on basis of a precise severity, the management issues arise because one has to be very sure about the severity, and there may be many loopholes in evaluation of severity. So I think Professor Roxy Senior is the right person to discuss the various aspects, especially on these loopholes in the diagnosis of aortic stenosis and their solutions, because he has done a lot of work on aortic stenosis. So Professor Roxy Senior, please.
Thank you very much, Professor Parashar, for this very, very kind introduction. And I'm really honored to be invited by Medanta Echocardiography Group, led by Professor Kasliwal. And I'll be absolutely delighted to present today, but let me share the screen first. Can you see the screen?
Yes.
All right. Okay, so my topic is on assessment of discordant aortic stenosis. Now, before we define discordant aortic stenosis, we need to know what is concordant aortic stenosis. So if you look at the slide here, let me actually minimize the icon and move this away. Yeah. So if you look at the definition of a grading of aortic stenosis severity, if you look at the definition of severe aortic stenosis, there are two main factors that define severity of aortic stenosis. One is the mean gradient across the valve, which should be more than 40 millimeter of mercury. And the other is the valve area, which should be less than 1 centimeter square. So if you satisfy both these criteria, then you make a diagnosis of severe aortic stenosis. But it is not that straightforward because you get discordance in these measurements, and that's where the difficulty comes in defining the severity of aortic stenosis. So what is the discordance that we see clinically? So the discordant hemodynamics we see is, we find that sometimes the mean gradient is over 40, which means it's severe aortic stenosis, but the aortic valve area doesn't suggest it's severe aortic stenosis. Now, conversely, you can find a situation where the mean gradient is less than 40, meaning it is not severe aortic stenosis, but when you look at when you calculate the aortic valve area, it suggests severe aortic stenosis. So these are discordant hemodynamics. Now, why should this discordance occur? The discordance occur because the gradient is flow dependent. So this is a plot of transvalvular gradient against transvalvular flow. And we are looking at three severity of aortic stenosis. So this blue line is patients with severe aortic stenosis, 0.7 centimeters square. And the red line is the borderline of severe aortic stenosis, which is 1 centimeter square. And the green line is patients with a moderate aortic stenosis, which is 1.5 centimeters square. So now, if you look at the area between the red line and the green line, which is moderate aortic stenosis, you will see that as the flow rate goes up to over 300, 350, the mean gradient goes to over 40. So here, though the aortic stenosis by valve area is not severe, but according to the mean gradient, it is. But that is because the flow rate is also high. Similarly, if you look at the area where the stenosis is severe based on aortic valve area, if the flow rate is down to say 125 or 150 or 175, you will see that the mean gradient is only 20 to 30. So despite the fact that the valve area suggests severe aortic stenosis, the mean gradient doesn't. And that is, as I've said, because it depends on the flow, what the main gradient should be. So how do we resolve this issue? So now let's look at the first discordance. That is where you see that the patient has a high gradient and the aortic valve area is more than 1. Now, in this scenario, of course, the fact that the gradient is high suggests that the LV is under strain. And even if the valve area is more than 1, the LV is still under strain. So now you have to decide what is happening with the flow. So as I've said, the chances of flow rate is very high in this patient. Now the flow rate can be high if the patient has, say, sepsis, or if the patient has developed severe anemia, or if the patient is thyrotoxicotic, hyperthyroid, or if the patient has some arteriovenous shunts, like the patient is on dialysis. Now, these are reversible flow states, meaning if you correct any of all these conditions, then the flow rate is going to come down. And when the flow rate comes down, the gradient comes down, and then it becomes concordant, meaning the gradient is down, the AV is more than 1. And now you know that patient has got moderate aortic stenosis, not severe, and you don't need to do anything further to this patient. So you should treat the underlying cause for the high flow state. But there are situations where the flow rate is high, but it is irreversibly high. And that is if it is compounded with moderate to severe AR. So if the patient has moderate AR, the flow rate goes up, though the AVA is more than 1, the gradient is high, and the LV is now subject to this high gradient. And because you can't do anything about it, you need to replace the valve. So once you replace the valve, you will correct the aortic, the reason for the high flow, which is aortic regurgitation, and the load on the left ventricle will go away. And therefore, here the treatment should be a valve replacement. Now, sometimes, even with conditions like anemia, etc., there are patients who are chronically anemic. You give transfusion, the blood, the patient still becomes, very anemic, meaning the hemoglobin drops. Now, in such a situation, if the ventricle is chronically under the load, and if the patient is symptomatic and the LV is dilating, then you will have no option but to go in and replace the valve. So this is how you manage this situation. However, the other situation where the gradient is low, meaning it is not severe, while the aortic valve area suggests it is severe, this is called low gradient severe aortic stenosis. You have first to be absolutely sure that your measurements are actually right before you condemn this patient to a diagnosis of a low gradient severe aortic stenosis, because it's a difficult condition and the prognosis is not very good in these patients. So now you need to be absolutely sure how you measure the transvalvular velocity, whether your sample volume is parallel to the flow of the blood through the aortic valve. You have to make it absolutely sure that it is. Then you have to look at how you measured your aortic valve area. Remember, you measure aortic valve area in echocardiography by using the continuity equation, which is defined here. You multiply the LVOT area by the LVOT distance, which is velocity time index, and then you divide it by aortic valve VTI. But if you look at the way the LVOT area is calculated, it is pi multiplied by LVOT diameter divided by 2, and then you square it again with 2 to get the LVOT area. Now, this is the greatest source of error when you measure aortic valve area, because you can see that even 1 millimeter difference in the measurement can lead to 10% difference in the measurement of aortic valve area. You can make the aortic valve area severe just by having an error of 1 millimeter. So you need to correctly measure the LVOT diameter. And I'll come to the details of that. And the other pitfall that we have is when we measure aortic valve area and say it is 0.9 centimeters square, but the patient patient's body surface area is less than 1.5 centimeters square. And now if you look at the corrected body aortic valve area, depending on body surface area, you'll find that it is 0.6 centimeters square per meter square. And according to this data, the patient does not have severe aortic stenosis. So you have to take small stature into account before you say that the patient's aortic valve area is truly in the severe range. So now let's look at the transvalvular velocity, what happens there. So for example, this is one of our patients where we did the echo, and we found that in the apical view, we are getting velocity of about 3.5 meters per second, a mean gradient of about 30. But if you look at the jet here, you will see that it is not dense, it is not uniform, and you immediately know that you are not in alignment with the jet. And you can see here, the sample volume is in this direction, while the jet is away from the sample volume in this direction. So now you have to really identify where you can really align it. So now we moved the probe to the right second intercostal space. Now you can see it is perfectly, so here's the aortic valve, and you can see the jet going right up. And now look at the measurement. It is now a mean of 91 millimeter of mercury, a huge difference from what you measured there. So immediately that discordant aortic stenosis has now become a concordant aortic stenosis, a high gradient with low valve area, and that's severe aortic stenosis. And if you don't do that, in 50% of patients, you underestimate aortic, the gradient. And in 8% of patients, you actually make a wrong diagnosis of low gradient aortic stenosis. So it is very important to identify the highest gradient from multiple sites. And the way to do it is to know that you get a uniform density of the jet, and that the jet is dense. And of course, you get the high, you get the highest peak there. So this is how you establish severe aortic stenosis. Now, moving on, what about LVOT diameter, which I've talked about? Now, the best way to measure LVOT diameter is to actually measure from the hinge point of the right coronary cusp to the anterior part of the septum, and then drop the line in parallel to the aortic valve plane, and there you get the maximum LVOT diameter. And this study by our colleagues, Philippe, etc., has shown very nicely that you reduce the variability if you measure in that way, because you have a landmark, and also it gives you the correct assessment of LVOT diameter. And this is compared with cardiovascular magnetic resonance imaging. Now, there's another way to know whether you are underestimating LVOT diameter, because that's what happens most of the time. We underestimate. And to know that, you do a calculation called calculated predicted LVOT diameter using this formula. And if your LVOT diameter that you actually truly measure in real time is within these 2 millimeters of what is predicted, then you have correctly measured it. So finally, this is another problem that we have. We measure that. So this is correctly placed, and you've got this hinge point, but you see a blob of calcium here. Now you move your transducer to get rid of that calcium, because it can be just occupying one plane, but not in several planes. So you move the transducer, and then you identify an area where there's no calcium, and then you measure it. And the other way to do it is to do it in 3D. With 3D, you do get the whole surface area of the valve, including the volume, the aortic plane. But the problem with that is, you will, unless the images are good, you may not get a good 3D image. But if the images are good, try to use 3D also, and that will give you the maximal LVOT diameter. And then we come to another pitfall, which I've said, which is measuring LVOT velocity jet. Now you have to be certain to place the sample volume just below the highest, where the flow accelerates, just below that, but not much below, because otherwise you will underestimate the VTI. And it is through the VTI that we measure the stroke volume, because VTI multiplied by LVOT area gives you the stroke volume and hence the aortic valve area also. So all these measurements are very important for you to verify if you find that the gradient is low and the aortic valve area is low. Now, once you have established that you've measured all of those correctly, then you have a diagnosis of low gradient aortic stenosis. And at this point, you need to define why the gradient is low. And as I've said, 95% of the time, the gradient is low because the transvalvular flow is low. So you measure the transvalvular flow status. Now, the transvalvular flow status by guideline is defined as a stroke volume index of less than 35 ml per meter square. Now, then you define the ejection fraction, whether it is less than 50%, then it's a classical low flow, low gradient aortic stenosis. But if it is more than 50%, it's paradoxical low flow. It's called paradoxical because the ejection fraction is normal and yet the flow is low. And you can get the situation, the flow is low, because in many of these patients, the LV volume is low. There is concentric LVH in these patients. They are elderly patients, women, and also they have restrictive type of filling. However, you can get a situation where the stroke volume index is more than 35 ml per meter square, meaning the flow is normal, and despite the flow being normal, the gradient is still low. And you get this situation in elderly population again, where your valvular arterial impedance is high, and that imparts low gradient, but the flow is not affected. So how do we deal with all this situation? How do we define the true severity of aortic stenosis? But the first thing to define is, are we measuring the correct flow parameter? Now, we are measuring stroke volume. So what is stroke volume? Stroke volume is a volume of blood, right? And this is opposed to flow, which we should be measuring, which is the volume going through a structure per unit time. Now, the flow is measured by dividing stroke volume by LV ejection time, which can be measured on the LVOT velocity jet. It's just the breadth of the VTI that you measure, and you get the flow rate. Now, the flow rate is the rate at which the stroke volume is ejected. Now, the same stroke volume can give rise to low flow rate or high flow rate, depending on the ejection time. So if the ejection time is prolonged, which can happen in a patient with bradycardia, which can happen in a patient with severe aortic stenosis, the flow rate will be low. However, if the ejection time is shorter, which can happen in a patient who's tachycardic, the flow rate will be high. Now, why should a flow rate be more correct than stroke volume in measuring flow? But first of all, I said, yes, the flow definition is volume through a structure, which is flow rate. But what is the other reason? The other reason is flow rate, if you look at it carefully, is actually LVOT area divided by VTI, which we know. But this VTI is distance, and distance divided by time is velocity. So it's area multiplied by velocity, and velocity is a measure of the force through which the blood strikes the valve. And that defines the gradient and the aortic valve area. And I'll give you an example here. So this is one of our patients who has got this low gradient, low AVA situation. So this patient was undergoing dobutamine, and you can see that the mean gradient is about 16. But at peak dose of dobutamine, the mean gradient has doubled to 32 millimeter of mercury. Now, though the mean gradient has doubled to 32 millimeter of mercury, if you look at the VTI, what's happening to the VTI? Now, VTI is stroke volume. If the LVOT area is constant, which it is, then the VTI defined stroke volume. You will see that the VTI was about 16. It did not change significantly. It's just 17. And though the stroke volume hasn't changed, you can see it's only 52 from 48. The gradient has gone up twice. So what made the gradient go up? What made the gradient go up is not the VTI, but the velocity. See, the velocity is going up each time in each stages of increase in the vitamin dose. And this velocity correlates with the flow rate. And you can see the flow rate has gone up from 164 to 209, and that defines this gradient. And you can see that that's why, you know, when we look at flow, we are looking at transvalvular flow rate, looking at the relationship between transvalvular gradient. And similarly, look at the aortic valve area change, which increase in flow rate, not stroke volume, but flow rate. So that's why it is important to measure transvalvular flow rate. But does it really translate into anything meaningful clinically? So we looked at our data and we found that actually flow rate is a predictor of mortality. So if the transvalvular flow rate is low, these patients do badly. And this is beyond stroke volume index. So you can see this is the information of prognosis that we see this mortality. Clinically, you know, you can predict mortality with reduced ejection fraction, the mortality grows up. But when you add stroke volume index, the mortality does not increase that much. But when you add flow rate on top of stroke volume index, you can see you get the best prognostic information. And what we found is that a cutoff of flow rate of less than 200 ml per second defines mortality. Over 200 ml per second, the patient does better. And this we also showed in a larger population of 774 patients across all hemodynamic spectrum of aortic stenosis, meaning those with high gradient and low gradient also. You will see that how if the flow is normal, generally, if it's normal flow, high gradient, the one we see daily in our practice, the outcome is better after operation. And also those with normal flow and low gradient, the outcome is better with operation, meaning there's likely to be severe aortic stenosis. While if the patient has low flow situation, whether it is high gradient or low gradient, the outcome is bad even after surgery. And we also showed that it is again beyond stroke volume index that is showing this predictability of mortality. And this is another study from the C study. I'm sure you all know what C study is. It's simvastatin and ezetimibe in aortic stenosis study. And they looked at group with moderate aortic stenosis patients. Now, even there, when they looked at flow rate, and I was part of this group because they wanted to look at flow rate, so they invited me to be part of this group. And it is on 1,600 patients. You will see it shows exactly that flow rate defines mortality. And this is beyond stroke volume index. Now, we come to another interesting thing to see. Now, if you look at the flow rate, and if you look at the severity of aortic stenosis, so this is a model actually, where the top is moderate aortic stenosis and the bottom is severe aortic stenosis. You will see that when the flow rate increases from low to normal, which is 200, the aortic valve area improves, even in group with severe aortic stenosis. However, when it reaches this threshold of normal flow rate, and if you increase it further, the aortic valve area doesn't open anymore. And this is in contrast to moderate aortic stenosis, where the aortic valve area improves more than in severe aortic stenosis in low flow state. But when you reach the normal flow state, the aortic valve area still continues to improve. So what it means is if you define a normal flow rate and the patient has an aortic valve area of less than 1, then this is severe aortic stenosis because the valve area is not going to improve any further, even if you increase the flow rate over 200. Now we took this concept and we looked at our study, And we said in this paper that resting aortic valve area at a normal flow rate reflects the true valve area. And this is shown in this data here. You will see that this is a group of patients who's got a normal flow rate. And you can see when we gave dobutamine, the aortic valve area didn't change any further. While when the stroke volume was defined as 35, which is normal, you see the aortic valve area improved. So it means that stroke volume is not actually defining the proper flow status. And on the basis of that, when we define the severity of aortic stenosis, so here you see, if this group of patients who had a normal flow rate with a valve area of less than 1, when we gave dobutamine, 16 of the 19 patients demonstrated a mean gradient of more than 40, meaning severe aortic stenosis. So the positive predictive value was 84%. So what it means is, if you see a patient with discordant aortic stenosis with normal flow rate, with aortic valve area of less than 1, this is severe aortic stenosis. You don't need to give dobutamine anymore because this patient has severe aortic stenosis. Now, this is just a cross-sectional study based on about only 70 patients. And on the basis of this, you cannot go out and say, I've come up with something unique. But this study was corroborated last year by Mass General Hospital, by Judy Hung's and Mike Picard's group, where they looked at 1,131 patients. And there they defined a group of patients with aortic valve area of less than 1 and a valve and the flow rate of 210, right? And they found that if the flow rate is over 210, above the threshold of 210, these patients had the worst survival, meaning these patients have severe aortic stenosis. And they were very kind to acknowledge our group here as being the first to actually show this data in our publication. And so what it means is, if you, with low gradient aortic stenosis, but with normal flow, the outcome should be good, meaning they've got severe aortic stenosis. That's why the outcome should be good compared to medical therapy. And this is what we've shown here. So we did a propensity matched analysis where 151 underwent medical treatment and 125 had AVR in this normal flow low gradient status group. And we propensity matched in 80 patients. And we found that those who had, these patients, when they underwent intervention, had a better outcome compared to medical therapy. So meaning these patients truly had severe aortic stenosis who benefited from intervention. And the other important thing what we saw in this group is that most of these patients had a mean gradient of over 30 with aortic valve area of less than 1. And if you look at the data of aortic stenosis, at rest, and this is from the Miniers group published actually 10 years ago, and they looked at valve area in relation to mean pressure gradient at rest. And what they found is 30% of the time it is discordant, meaning the mean gradient was less than 40 and the valve area was less than 1, discordant aortic stenosis. And you will see that the gradient that they come up with in this discordance is about 30. So the definition of aortic stenosis itself gives you some discordance. So what it said is, if the valve area is less than 1, then your gradient will be between 34 to 40. In order for the valve area to be less, for the mean gradient to be less than 40, you have to have a valve area of 0.8. Now, we knew about that, and the societies knew about that. So they defined aortic valve stenosis as aortic valve area of less than 1 and mean gradient of more than 40, because aortic valve area of less than 1 is very sensitive, but mean gradient of more than 40 is more specific. So they combine the two. What we are now saying is that if you have a normal flow and the valve area is less than 1 and the mean gradient is more than 32, these patients should be intervened on because they do well with operation. And so when you assess aortic stenosis, you should always assess flow. And this is the editorial that we wrote in JACC, and we said, time to go with the flow, right? And this is how, and this is actually from the paper that I've just described. So they came up with this algorithm, which is based on our data. And you can see, so this is a discordant group. And if the mean gradient is less than 40, right, aortic valve area less than 1, but if the flow rate is more than 210, then this is severe aortic stenosis. And as I've shown, that these patients actually do better with intervention. And if you're still not sure, if you find that your mean gradient is not 30 but 29, but your flow rate is normal, then you look at the calcification of the valve. Now, if the calcification is dense and your flow rate is normal, then it is severe aortic stenosis. So you've got 2 or 3 parameters. And of course, if your mean gradient is more than 30, it is severe aortic stenosis. So now we come to a situation now where it is not normal flow, it is low flow. So when it is low flow, you've got 2 situations, as I've told you before. All you need to do is to normalize the flow. So when you normalize the flow, what happens to the aortic valve area? So what happens to the aortic valve area? When you normalize the flow, so this situation, low gradient with reduced LVF, and now you are giving dobutamine. Now, when you normalize the flow, if the gradient is more than 40, aortic valve area is less than 1, then it is truly severe aortic stenosis. When the gradient is less than 40, but the valve area exceeds 1, then it is not severe aortic stenosis. However, you still have a situation where your mean gradient remains less than 40, aortic valve area remains less than 1, so still it's indeterminate, and that occurs in about 30% of patients. Then you calculate the projected valve area, and it's below the, you can see the formula. This is from Peeber and Clavel's group, and you project the valve area to 250 ml per second. And if the valve area after projection is less than 1, then it is severe aortic stenosis. So in conclusion, when you see discordant aortic stenosis, especially low flow, low gradient, you have to check all the measurements. And if despite that, it is still showing low gradient and low aortic valve area, then you check the flow rate. If the flow rate is normal and your mean gradient is more than 30 and there's a calcified valve, then this is severe aortic stenosis. You intervene on that valve. However, if the flow rate remains low after calculating the flow rate, then it is still indeterminate. You give dobutamine, and after giving dobutamine, if you get the right parameters, then that's fine. If not, if it's still indeterminate, then you look at valve calcification by CT or even echo, or do projected valve area. Now, in patients with low flow rate but normal ejection fraction, dobutamine has a bit of a problem, because here in this situation, the LV volume is usually low. They usually have a restrictive filling. If you give dobutamine, you will reduce the volume even further, and the flow rate doesn't go up that much. You will come up with indeterminate flow. So it's best to just go for valve calcification assessment by CT or echo and make your diagnosis. Thank you.
Thank you, Roxy. I think for the audience, we'll have some question answers in the end. But one thing is apparent, the amount of work and the quality of work Professor Roxy has done has been acknowledged all over the world, not in center also. So you keep ready with your question, answers, and discussion will be on later on, because we have a next very interesting presentation by Professor Kasliwal, who I think everybody knows is the sort of professor of both. My goodness, it's a huge, big. You can see you can read it yourself, that how much excellent work he has done, how much experience he has got both in clinical and preventive cardiology, and in echo and in echo. So he is a rare combination of clinical, preventive, invasive, and in non-invasive cardiology. So he is a chairman of the Division of Clinical and Preventive Cardiology and a community outreach program. And I think he has done a tremendous amount of work of which everything is written here. So he is going to present a case and then we'll go to the discussion. You can keep your question answers ready. Professor Kastiwal, please.
Thank you, sir. So, Roxy, thank you so much. I mean, this was overwhelmingly scientific. So, I think when we said putting latest science in clinical context, thank you. You've done exactly the same. My, I and Dr. Manish, we were discussing to take this science to the real world, and therefore I have a very small presentation, about 7-8 minutes. And this gentleman was a 79 years old male. He came to us with shortness of breath. He was NYHA grade 4 for dyspnea on exertion, diabetic, hypertensive. He had actually underwent CABG for 3-vessel disease in another hospital 2 years in 2018. And at that time, his ejection fraction was 35%, and he was doing fairly well. He did have aortic stenosis, but nothing was done for it at that time. And when he came to us, he was on aspirin, clopidogrel, valsartan, amiodarone, and he was on oral antidiabetics as well. But what struck me was that he was almost, I mean, he needed oxygen all the time, and he was class 4. He was conscious, he was oriented. His blood pressure hovered around 110/60. He had tachycardia, SpO2 was 92, and he had an ejection systolic murmur over the aortic area, well heard in the second, third intercostal space and going to the carotids, and he had bibasal creps or lung auscultation. As Dr. Roxy said, many of them have anemia. He had anemia as well. And urea creatinine were 1.4 was the creatinine levels, sodium, potassium. Sodium was on the lower side. LFT was normal, troponin was, but strikingly, his NT-proBNP was very high, and the ECG showed changes of anterior wall MI. The echo, and sometimes we have to say that echo, we can't have textbook type of echocardiographic images all the time. So here was a situation, and you can see very clearly, even the mitral leaflets were thickened. But what struck me here was the sample volume positioned across the aortic valve, and we found a mean gradient of 25 with a max gradient of 45 millimeters of mercury. So, and of course, he had an ejection systolic murmur. So, his mean gradient across the aortic valve was 25 millimeters of mercury. Peak gradient was 41. The dimensionless index was 0.20. Ejection fraction was just 20%. Stroke volume was 24 mil per beat per meter square. And we found a valve area which was just 56. So what I thought was that the valve, the aortic valve, which was stenosed even at the time of his surgery in a sister institution, was still there, and that it had increased. But importantly, he had also got left ventricular dysfunction. So all in all, this gentleman had diabetes, hypertension. He had 3-vessel disease. He was post-CABG, severe LV dysfunction, ejection fraction 20%, and severe degenerative valvular low flow, low gradient, severe aortic stenosis, and was in functional class 4. Now, as this has already been discussed, I will not go into all that, but I will just say that when you have a reduced stroke volume, that's what Roxy was saying. You should think of low flow, low gradient AS, and not just leave it alone and say, look, the gradient was hardly anything, so we left this patient alone. He wouldn't have ever made it in life. So in general, low stroke volume in AS indicates poor prognosis, regardless of whether the LVF is normal or reduced. But in LF-LG-AS, this has to be taken seriously. And of course, one needs to ensure that there is no measurement error. That's what Dr. Roxy has also said, that if you look at the other side, if you look at paradoxical low flow, low gradient aortic stenosis, small LV size, old age, female patients, smaller body size, LVH, increased afterload, can also give rise to a situation like this. But if you were conscious of your flow rate and of the stroke volume, then you would correctly make a diagnosis of low flow, low gradient, severe aortic stenosis. But before, so obviously this gentleman could not have been put up for a open heart surgery. He was so, ejection fraction was low and he was in poor health. Before you plan any intervention, you will have to look at the status of coronary arteries in this particular patient and the grafts, because he had bypass surgery done. Valve morphology, whether it is bicuspid or tricuspid, sometimes there's so much calcium, you may not be able to wake out even. Extent and location of valve calcification, as Dr. Roxy also said, makes a lot of difference where the valve will hinge. Ascending aorta, size and anatomy, aortic atherosclerosis, calcification, LVOT anatomy, septal hypertrophy, concomitant lesions, all this is important. Very nicely, the physician will come and say, sir, why don't you do a tower on this gentleman? And then you're all sitting down and saying, that we need to have this data before we can actually even think about it. Concomitant lesions, LV systolic function, and then you establish the risk of intervention. And as Dr. Roxy has also said, that when the ejection fraction goes down, the mortality goes down exponentially. So you have to be clear about the diagnosis. You have to be clear about the flow rate. You have to be clear about the stroke. And then, of course, you have to take the, the systolic volume, the systolic gradient from whichever is the best position. So the first thing that we did, obviously, in this patient was we did a coronary angiogram, and we found that he had typical, what we call as diabetic coronary arteries in our country. You can see 3 vessel disease. You look at the right coronary artery, it is hardly even visible. The first graft that I did showed a good flow. This was graft to the OM, and the right coronary artery as well was flowing very decently. And then the graft, which was put this as a saphenous vein graft to the LAD, had a stenotic lesion just where it met with the native LAD. The panel on your right here just shows the amount of calcification that this gentleman has. And obviously this comes in the way of any procedure. So CT scan findings are there, and obviously, as Dr. Roxy said, you have to look at the echoes carefully, but also annular size, LVOT size, because you have to be very careful. If you are planning a TAVR, then you have to be very clear about these things. And then you take maximum ascending aorta diameter, sinutubular, and the whole thing. We decided on the tower after this because we found that he was too high a risk for open heart surgery. And he'd already had a surgery in 2018. But simple as it may look, just look at the calcified aortic arch. Just look at the annular calcification extending into the LVOT, the dissected right femoral artery from the previous infarct, from the previous angiography, and maybe he had an intra-aortic balloon pump there, calcified left femoral artery, and a compromised coronary circulation. I'm just saying that this is the scenario today when we talk of a procedure which is going to be extremely costly in our situation. You have to be very, very certain what you want to do. So we found the access from the left femoral artery, and an arteriotomy had to be done. And then we took a Medtronic core valve, the elvolute, and then this was, so if you can see the number of catheters here, you can see the catheter with the valve, you can see the temporary pacemaker, and the whole approach was done from the left side. And here you see a open valve. Now here the calcification helps because it hinged onto the aorta very well, and there was not really any regurgitation. What it behooves of, what it shows truly is the value of good clinical science added to good echocardiography skills. Stage of this procedure, and even thinking that we want to do a procedure like this, echocardiography came in so handy. At that time, of course, we used to do Ps, and we used to do transthoracics in the cath lab as well. Now it's not, mostly it is not required, though in sometimes they do call us. But post-operatively, we had a decent valve gradient, and I'll come to that. Post-tower, you will already see that the ejection fraction is improving. This is the valve where there's hardly any mitral aortic regurgitation. This is the for chamber view, and these are the valve. This is the gradient across the valve, and so the mean gradient across the aortic valve pre-tower was 25, post-tower was minimal, peak gradient 41 and 10, DVI was 0.20 and 0.72, stroke volume index now 24 and 36, ejection fraction also marginally increased, and the valve area, of course, improved. So the main thing that comes in is that one has to be clear about the kind of aortic stenosis. The flow rate has been emphasized and re-emphasized. The ejection fraction done carefully, and the stroke volume indices and the dimensionless index. These parameters are extremely important. That coupled with an aortogram will give you a diagnosis, because you have to also prognosticate whether the patient will do well or not. But this, I thought, was a classical indication. The patient was 79 years old. He'd already had bypass surgery done and had low flow, low gradient, severe aortic stenosis. So the patient withstood the procedure well. He had improved symptomatically. Before the first lockdown, he had met me. His ejection fraction was in the range of 40. And obviously, before he went, we also did an angioplasty to the SVG to the LAD. So 2 grafts were functioning even before. Then now all 4 tires were working, and he got a valve as well. So when performing a tower procedure, a multidisciplinary approach and a multimodality approach is always the best way to go, the best to help you prepare for any for any complications. And therefore, they say that, if you are self-aware, you can reduce panic. A pre-case discussion is very important in every step. When the patient came in, right from that time, he was NYHA4, hardly any murmurs were heard, and later on, the cardiac output increased, and a good echocardiogram was done 2-3 times before we actually came to this conclusion. A multidisciplinary heart team approach is extremely important. When somebody said from the American Heart Association, the heart team approach, actually, most of us in good centers, were already doing a heart team approach. Interventional structural heart specialist, a clinical cardiologist who's fully specialized in the full nuance of echocardiography, heart failure, cardiothoracic surgery, and when required, cardiac anesthesiology and vascular surgery. So, ladies and gentlemen, I think here is the situation, here is a case who saw the light of the day, not just by the skill of one person putting in a tower, but actually several minds who were independent thinkers in their own field, but who came together to make this happen. And definitely, as Dr. Roxy has said several times, that this has to be done painstakingly, with time at your disposal, and definitely looking very carefully into the flow parameters. So thank you, Dr. Parashar. Thank you, ladies and gentlemen. I would say one team, one goal, every life priceless. And that is so true in today's paradigm as well. Thank you very much.
Well, I think it was such a, although it is say multi-team, but I congratulate Ravi and his team who have excellently worked up this case. They have gone into every detail of the case to give a diagnosis and possibly save the patient because of their efforts or so. Now, from both the presentations, it is very difficult to give a summary, but at least for those who are level 2 echocardiographers who are doing an echo, I think some message which at least we can give is, number one, always before you jump to echo, always have a good clinical assessment. Take a good clinical history. Ask the patient whether he is asymptomatic or symptomatic. do a good clinical examination as they found an anti-systolic murmur here, then always don't hesitate to take the height, weight, and the body surface area, which will be used many times or so. Always record a blood pressure in the case of aortic valve when you are doing this, and also your ECG X-ray. Once you have finished this pre-echo thing or so, then you go to the echo, starting from the morphology of the valves and other things. And the three things which you have to see, which Roxy also pointed out, was a peak gradient and a peak velocity, mean gradient, and an aortic wall area. Both the three things require a regular practice. And as you know, as has been pointed out, you have to take all scan planes to get the maximum velocity, because all your calculations depend upon the velocity and the VTI. So take all scan planes and record maximum velocity. And as Ravi pointed out, it is high time that in every case, you start calculating a stroke volume index. I think if you have got difficulty in calculating total flow rate, which is not difficult, don't confine yourself by just taking a peak and mean gradient. Try to find out an area and also a stroke volume index. Always see a good LV systolic or a diastolic function. So the sequence will always be a 2D echo, if need be a transesophageal echo, if need be a 3D echo for an LV volume plus LVOT, and a strain imaging which has not been discussed, but it is a very important part of various valvular heart disease also. So keep this mind rather than going straight to the echo. So now we come to some of the questions which have been put also in the uh, some of the answers have already been given out the recordings or so. And so in, one of these questions is, can you please guide the frequency of echo follow-up for moderate AS for discordant aortic stenosis? That is for Roxy.
Yeah, I think it's a good question. So so the question, if I've understood correctly, is in moderate aortic stenosis, you have a gradient of say less than 20 and aortic valve area of more than 1. So whether this is mild or moderate, is that the question?
No, he's saying how frequently will you see the
For
patient?
moderate AS for discordant aortic stenosis.
All right, high frequently you see moderate aortic stenosis. Okay.
And how frequency the echo should be done?
How often the echo should be done?
Okay, so once you've established discordant aortic stenosis and you've done all the tests, in those with discordant aortic stenosis, 30% of the times you'll find that it is severe. The other 30% of the time you'll find that it is moderate. And the other 30% of the time, you will have to rely on other modalities to make a diagnosis, and that is mainly CT. We use CT calcium a lot to make a firmer diagnosis of severity of aortic stenosis when it remains indeterminate despite all you've done with echocardiography, including dobutamine. So to answer your first question, in 30% of the time you see moderate aortic stenosis. And once you, so the question is, how do you follow these patients up in moderate aortic stenosis? We follow these patients up every year. But if the patient is symptomatic, we actually follow them up every 6 months, because some of them can be quite borderline severe aortic stenosis, like, the valve area is 1.1 and the mean gradient is like 31, 32. The patient is symptomatic. We follow these patients up every 6 months because we know the gradient can suddenly increase and the patient can be in big trouble very quickly. So this is how we do it.
So the second question, I think initial part I can answer, then I'll ask a very important question from Roxy. that the question is any benefit of using GLS in aortic stenosis? Yes. So as you know, in aortic stenosis, there is a significant concentric LVH, there is a wall stress, and ultimately the subendocardial fibers or the longitudinal fiber, they get affected. First, as compared to the ejection fraction, because by the time your ejection fraction falls, sufficient myocardial damage has been done, and the global longitudinal strain picks up incipient LV dysfunction when all other functions are normal. So it is being increasingly utilized because ejection fraction can be normal, but GLS can be decreased. So the question to Roxy is that one of the indications for surgery is an ejection fraction below 50%.
Yeah.
Now, suppose the ejection fraction is normal and the GLS is abnormal, which is expected. Should they go for intervention? And number two, should GLS be routinely included in the various guidelines when we list aortic stenosis or any valvular heart disease? Because it has got much more value than ejection fraction. These two questions for Roxy clarification, not only for clarification.
Yeah. So, I mean, there's no question that GLS looks at global longitudinal strain, and strain is the subendocardial fibers, which are arranged longitudinally, get affected first. The ejection fraction remains normal because the circumferential fibers, the radial fibers, they compensate. And therefore, the ejection fraction is maintained while the global longitudinal function goes down. Now, the problem, of course, is not so much as the mechanism, but the reproducibility. Now, as you know, that the value of global longitudinal strain varies from machine to machine. In Philips, it's different. In G, it's different. And also, even in the same machine, if you measure twice, you can have slightly different values. Now, in your lab, if you've done a reproducibility study and you have a good reproducible global longitudinal strain, then you can take that as the gold standard and say that, okay, this patient's now got low global longitudinal strain, though the ejection fraction is normal, the patient is symptomatic, I would preempt and intervene on this patient. However, there is no large data advocating global longitudinal strain as the only criteria to advocate intervention based on reduced strain. So we don't have the data yet, but anecdotal data are present where they have shown that actually intervening early, because if you leave it, these patients can come with crashing heart failure, and they've shown that. But there is no large-scale data to support, as a whole that you should do it. But my personal recommendation is, yes, if you have a markedly reduced global ejection, longitudinal strain with a normal ejection fraction, and the patient is symptomatic, then you should, even if the patient is asymptomatic, and the patient has got severe aortic stenosis, then you should consider intervention in such a patient, provided it's done reproducibly.
Thank you. Thank you. The third question is, can we do tower in bicuspid aortic valve patients? Ravi, for you possibly?
Yes, we are doing it in bicuspid with good results. Let me just answer the first question from our perspective, that many patients with severe valvular aortic stenosis claim that they are asymptomatic, and yet their mean gradients are above 50 or 60. There, you doing a global longitudinal strain comes into this thing, because we can tell them that because we do only from one lab and from one machine and just 2 or 3 people, so it's almost standardized that if the global ejection fraction is below, the GLS is below 17, then it's a good indication in a so-called asymptomatic person to do valvular surgery. That's what we do.
No, absolutely, I agree.
My colleagues, Dr. Kapoor and Dr. Praveen Chandra, closely with Dr. Manish Bansal, they have a good series of patients who actually had bicuspid aortic valves and towers. So they have a good number of patients.
Well, Roxy, you have lot of experience of stress echo in aortic stenosis. In just a few points, in which conditions, okay, the problem is that being an asymptomatic patient, because they are used to their symptoms. There was a very nice paper by Ramdas Pai et al. That 3% of their patients with ejection fraction less than 20% claimed to be asymptomatic, and 10% below 30% claim to be asymptomatic because they utilize their lifestyle like this. But which are the main groups where you will do a stress echo in aortic
So,
stenosis?
yeah, so the patient got severe aortic stenosis and is asymptomatic. Obviously, what is very important is to tease out from the patient, are they truly asymptomatic? So you ask them some very relevant question that, oh, okay, how quickly can you climb the stairs? Now the patient will say, well, I can climb 2 flights of stairs very easily. Then the next question you ask is, how quickly can you do it? He said, oh, well, I actually do it. I take some time, but I still do it. So then you immediately know that the patient has slowed down. And then the next question you ask is, 2 years ago, were you running up the stairs? The patient will say, yes, I'm now walking. 2 years ago, I'm running. So as soon as you hear this, you know that the patient is not quite asymptomatic. Now, there are patients, of course, who completely deny the symptoms. No, I have absolutely no, I'm absolutely fine. In those patients, we do a stress echo. We exercise them. And on exercise, obviously, we see that if they don't, so, many of these patients are elderly. So our criteria for good exercise is that if they achieve more than 7 METs on the treadmill, then they have no symptoms. But if they do less than 7 METs and they stop because of dyspnea, especially, then they are symptomatic. And 2, of course, we also look at the gradient, how quickly the gradient is going up. So if the gradient goes up by more than 20 millimeter during exercise, these patients actually end up having a valve surgery very, very quickly. In fact, they even get admitted with heart failure. And thirdly, we look at ST changes, we look at blood pressure drop. So we look at all these parameters and then take a decision of what to do with the patient.
There is now one more question has come. A 55-year-old patient having moderate primary MR and moderate to severe aortic stenosis, AV area like 1.0 centimeter square, and patient is symptomatic. His EF is 55%. So what will be next step for patient treatment? Should we correct the MR first or the aortic stenosis first? It is written ischemic and primary MR. Okay, primary MR, yes.
Okay, so the patient has got a, so again, the patient has got a moderate primary MR, right? And the patient has got moderate to severe aortic stenosis, meaning the aortic valve area is 1.
Yeah.
And the gradient is possibly about 30, 31, 32. I don't know. What was the gradient? That's important to know.
That is not mentioned here.
Not mentioned. Okay, fine. So I assume that it's borderline. So under those circumstances, we have to prove that the patient's symptoms are actually related to the valve. So in order to do that, I will exercise the patient and see whether during symptom, the MR deteriorates to severe, because MR is, as you know, if it's mitral valve prolapse, it is very labile. On exercise, it can become worse. And at the same time, we can see what happens to the LV, and we see what happens to the aortic valve gradient. And then make a decision after that.
But if the patient has got a severe aortic stenosis also, and you are already doing a wall replacement and changing the wall, why not correct the mitral regurgitation at the same time?
Oh, no, absolutely. So even so, for example, on exercise, we find that the patient's severity is related to, say, MR. But during the operation, you're going to replace both the valves. And similarly, if you find that the aortic stenosis is responsible, you'll still replace both the valves. But first of all, you have to prove that one of the valves is actually causing the problem.
Yeah.
Because
Right.
remember, the patient is 55 and the patient, you can replace the valve. You're likely to you might give the patient a mechanical valve and the patient will be on warfarin for the rest of his life. So you have to really think very carefully when to intervene on these patients.
Well, I think we must congratulate Professor Kastiwal for starting this series. This question was from Muscat, Oman. So, because they are very educative sort of a series, and I hope they continue for a longer time because they produce a lot of interest also. And we congratulate you, Ravi. At the same time, what an excellent talk by Professor Senior was given, made it so clear, everything was so clear also. So if there are no questions, any final comments from Dr. Kastiwal?
No, thank you very much for these comments. And I think that having both of you in this session was actually the icing on the cake, because a very fine lecture. And Professor Dr. Parashar is an icon in our country, and so is Dr. Oxy Senior. But the important thing is that the way you have brought the science into this thing, and we're all talking of science in the last 2 years. So I think this has been a very good session, and we will of course continue it every fourth Saturday. We try to put our best foot forward, but we could never do this until unless we have faculty like you. So thank you very much, both of you, sirs, and till we meet next, au revoir. Thank you very much.
So thank you,
Thank you.
Roxy. Thank you very much, all of you.
Thank you.
Thank you.